Thank you for the opportunity to tell you a little bit about the work that we're doing and how it applies to the pediatric population. So I work in brain cancer in general and lots of fusion of imaging to finding pragmatic neuro-oncology solutions for these patients. And so everything here starts with the patient. So every patient, of course, we know is different. We've heard a ton about that today, but every patient is really dynamically distinct. So these are 15 newly diagnosed, in this case, adult glioblastomas, but I can make similar pictures for pediatric cases where they're receiving all exactly the same therapy, but you see this radically different response across this cohort of patients. They're all receiving standard of care radiation chemotherapy followed by adjuvant chemotherapy. And there's some patients with a robust response. And that's what I would argue that those are the patients that are obviously scooching our curve slowly out as we advance with therapeutic approaches. But underlying the biology of this disease is this reality. If you zoom in at a single voxel level within each of these patients' brains, you're going to find individual tumor cells proliferating and invading through long extents across the entire brain. So it's not just what you see on imaging that's really telling you the whole story. You really have to have better understanding of the integrated whole across the entire spectrum of the patient's brain. So we use a lot of computational approaches to do that. So as a mathematician, I can look at that movie and I can say, this is a complex system of interacting agents. Those interacting agents might have some rules. They have rules, they're migrating. I can write that down in terms of an equation, D, diffuse invasion. They're proliferating because they're cancer. And hopefully they're responding to the therapy that we're giving to the individual patient. So you can, if you write down those sort of minimal models, you have a chance to be able to sort of integrate the information that you have at the patient MRI level. And what I mean by integration is, I mean this. You can take on the top, what you'll see here is the MRI extent for the contrast enhancement. And at the bottom is sort of the diffuse invasion predicted by connecting those serial imaging in these individual patients to those individualized model parameters from that computational model that I showed you, not to scare you, but to simply tell you there is computation underneath it all. And pragmatically, you can also add in overlay therapies. So here's an actual patient that's ultimately going to receive a temporal lobectomy with significant residual disease. You see with radiation, the residual disease seen on imaging in red dissipates, but then we have this dramatic recurrence. But what we're not showing here is the shades of gray of the individual diffuse invasion of this disease. So we have those, we have ways to sort of take routine patient MRI and predict some extent of diffuse invasion that you wouldn't otherwise normally see. And we've iterated on that in a variety of ways. So that's just sort of like a baseline framework that you can really apply to sort of any set of serial imaging you have in patients to better understand the dynamics of disease. We're working on this a bit with Miriam Aboon at Yale to look at one of the PNOC cohorts and probably can tell you more about this in a couple months. Additionally, in addition to collecting all of this work that we built on sort of quantifying individual patients' tumors in terms of their dynamic rates of proliferation, invasion, and other phenotype, we've been looking at how to parse out which patients are going to do what. And so one of the most interesting findings we've had over the last several years has been in the fact that there are not only sex differences in biology, you hear about this all the time, right? There's increasing understanding that there are important biological sex differences in our understanding of brain cancer. But what I'm going to compel you here is there's different patterns lead to different outcomes between the sexes. So what this graphic shows you is that for predictors of overall survival, the blue curves are different than the red curves. So the males, what predicts overall survival in terms of imaging phenotype, those green arrows, is different for males than females. And so basically the imaging characteristics of what is ultimately bad or good for a patient is different. Further, everything I've told you about the biology so far of this disease is that it's diffusely invasive and it's kind of everywhere in the brain in general, but in the degree to which you can quantify that difference matters in terms of being able to differentiate out patients. But the real problem with this disease is intratumoral heterogeneity. And if you were to biopsy an individual patient, you get some sort of answer. You're like, okay, great. This is my precision understanding of this disease from this sample. But there's always these cells left behind in the brain because it's such a diffusely invaded tumor that we really have to grapple with the whole complex heterogeneity of the disease across the entire brain. So you have to be able to sample at lots of different locations, get a mapping of not only the reds and blues, but really the rainbow, and accept the fact that the rainbow is evolving over time. So really the future of precision medicine is more of a holistic understanding of how those pieces integrate together. And the most pragmatic view onto that we have day to day is MRI. So the idea that we've really leveraged over the last couple of years has been able to use lots of image localized biopsies and build a consortium of that set of information and collect those together to fuse multi-parametric MRI into predictions of that biological heterogeneity, not unlike what we just heard about for the on the upfront setting for like understanding macrophages, which I show you here. We have a UL1 that's focused in this area, but in a variety of other circumstances. So even in patients for which we have scant, maybe even diffuse midline patients where you have scant biopsies, by collating all those patients together and knowing where those samples come from, you can start building a better repertoire of our understanding of where those, what the biological heterogeneity is within each of those tumors. And what we do is we basically take these neuronavigationally guided biopsies, we take local regional imaging information, whatever biology we're looking at, could be histological, could be transcriptomics, could be sequencing, whatever it is, and we build machine learning or mechanistic models that connect those, that glue those two pieces of information together, and then you can build maps. So we can predict what the biology is in a place that I didn't sample. Okay, well, how do you, first of all, I mentioned sex before, and I'm going to reiterate it again because I think it's unbelievably important. I'm going to reiterate the fact that the MRI to biology mapping is different between males and females. So basically the wire diagram you're seeing here is for EGFR amplification, PDGFR amplification, PTEN deletion. These are examples in adult gliomas, but the imaging features that predict those different biological outputs are different between the sexes. They're just objectively so. So much so that if you build models for them, the accuracy of those models are radically different. And they're better if you separate into two separate piles, a male pile and a female pile, even though you have less data to feed those models. So how can you use these sort of approaches? You can look at regional response to their targeted therapies. This is, again, I'm giving lots of examples from adults, but we're building, as I'm relatively new to the PNOC group, we're beginning to target overlaying sort of insights into this heterogeneity. So here's a patient that received an EGFR targeted therapy. And if we only knew beforehand whether this tumor itself was EGFR amplified or was it EGFR amplified over large swaths of the tumor, that would be useful. It turns out if you overlay the red region is kind of small. The red region is where you predict, the model predicts the EGFR to be amplified. So only a really subset of the tumor was really expected to be responsive to the targeted therapy. And that was the region that actually shrunk over time, whereas the region that progressed was not EGFR amplified. We've looked at this and now in clinical trials, and this is the parallel of the work that we're trying to do with PNOC, is where you overlay this information now at looking at clinical trials where you've got 3 different example patients, one that at the top is the pre-treatment and the bottom is the post-treatment image, three months into treatment. And you see that there's the leftmost patient ultimately looked like the tumor was progressing, the middle patient was sort of stable, and the right patient was decreasing in size. And if we had known ahead of time using these models that the target was present, in this case, again, it was an EGFR targeted therapy, but I can fill in the blanks with anything, you would have known ahead of time that that patient on the right was the one that would be expected to get the most bang for their buck from that therapy. And so we're building this out in partnership with a lot of clinical trials to be able to make this a manageable workflow. So the workflow is even more complicated in the case of immunotherapy. We heard mention earlier of the idea of pseudoprogression being a real challenge. It is. We all know about this. So we've looked at a variety of trials. I'm just going to give you an example of a dendritic cell vaccine trial where we've overlaid this information for a population of model predicted T cells. So where are the T cells at? If the dendritic cell vaccine is working, hopefully T cells are showing up and doing something. And in this case, basically you want red. The more red you get, the more quote T cells, the more model predicted T cells are there. And you can see that 2 months in, the top patient only lived 5 months and the redness was going away, right? So there's less of the T cell abundance, whereas the patient on the bottom sees this shift. It's a little bit, but it's measurable, an increase in T cell abundance. And it basically, you could separate patients out. If it increased, if the abundance of predicted T cells increased, the patients did well. For an otherwise failed clinical trial, because it's an early phase 20 patient trial, right? We're just sort of moving along thinking we're trying to move forward, and how can you better identify and distinguish which of those patients that are getting the best bang for their buck. So basically the idea is stitching this all together is the work that I've been doing with PNOC and other associated databases that we're talking about today, is trying to build out on methods like this. So hopefully I'll have a lot more useful information to tell you about that in several months. Thank you for everybody that does all the work. Oh, wait, went one step too far. That's all the people that do all the work. Thank you.